Good afternoon, good evening, and good morning to everyone watching us from around the world. You are all welcome to the Africa Respiratory Care webinar series. And today we are excited because we are going to learn something new, and not new, but we are going to get more insight into something very critical, yet we take for granted. And before I start, my name is Dorothy Honeybender. I'm the founder and president of the Africa Respiratory Care Association. And at Africa Respiratory Care Association, also known as ARCA, our mission is to enhance respiratory care across the continent of Africa and the world at large, supporting respiratory care workforce, bringing innovative solutions into respiratory care, and obviously saving lives across the world. And this webinar is proudly brought to us by the Africa Respiratory Care Association and sponsored by Zopec Medical. Zopec Medical is a leading manufacturer of ultralight, uninterrupted power supply batteries designed for medical, IT, and general electronic applications. These uninterrupted power supply batteries provide seamless transport, emergency backup, enhances mobility, ensures reliable power when it matters most, especially when it comes to power outages in Africa. So if you are a healthcare provider or you are a hospital administrator participating in today's webinar, this is an opportunity for you to back up your equipment and also enhance patient care in your facility. For more information on these uninterrupted power supply batteries, contact Zopec Medical at cs@zopec.com. You can also contact them on the information showing on our screen. That is +1 888 468 7108. Or you can also reach info@africaresp.org for further information. If you also want to distribute or be a distributor of this UPS batteries across your country, reach out to Zopec Medical or reach out to the Africa Respiratory Care Association, and then we can give you the direct guidelines to reaching this company. And then if you are a vendor or you are a company or an institution that you or want to enhance our initiative and what we do in promoting healthcare across the continent, or want to be part of the life-saving initiative, kindly reach out to the africareps.org for more information. You can be a vendor member to support our initiative. You can also be a donor member, or whatever you also want to do in saving lives across the continent. Today, I am so excited because the presenter is a very great personality, and she has over 20 years of experience as a respiratory therapist at MedStar Washington Hospital Center. She earned her Associate of Applied Science in Respiratory Therapy from Prince George's Community College in 2008. She recently completed her Bachelor of Science in Respiratory Therapy at Towson University to further advance professional growth and expertise. She is currently a respiratory therapist, registered respiratory therapist with an adult critical care specialist credential. She has served as a clinical instructor at Prince George's Community College for more than 10 years, mentoring and training future respiratory care professionals. She specializes in the care and management of patients with acute chronic respiratory diseases, including asthma and chronic obstructive pulmonary disease, also known as COPD. She is passionate about community outreach and patient education, particularly within underserved communities. She is dedicated to improving patient quality of life through education, disease management, and health empowerment. She enjoys collaborating with interdisciplinary healthcare teams and engaging in continuous learning during patient care rounds. She is committed to giving back to the community and inspiring others to contribute to respiratory care advancement. And obviously, she is a member of the Africa Respiratory Care Association. Our presenter today is Malisha Kichwen. Malisha, our audience, our presenter. Thank you.
Hello, everyone. It's definitely such a pleasure to be here with all of you. Going to start to share my screen here. And thank you. It's so wonderful to be on this platform, to be able to speak to all of you about something that can potentially save millions of lives just by bringing awareness um, to to biomass smoke and what it actually does to the body. Um, I've been a therapist for a while now. I work primarily in adult critical care. So I get to see patients when they're extremely sick. Um, so being a respiratory therapist has really given me the opportunity to save lives, definitely give back to my community, and to train and educate up and coming respiratory therapists. And today, my purpose is just to bring awareness and change to a popular source of energy that is used worldwide. So, I once was caring for a patient that came in, got admitted to the ICU for COPD exacerbation, and she said she never smoked. Anyway, she was having oxygenation issues, using a lot of accessory muscles, had to be placed on BiPAP, was wheezy. We gave her treatments, albuterol, Duanab, treated her with steroids. But going through her past medical history, no history of smoking, and no one smoked in the same house. So she really hadn't been exposed to cigarette smoke. So initially, I thought maybe she was just excluding the fact that maybe she was a smoker, um, but she never smoked. So this is what started me on a deep dive into why a 60-something-year-old woman would be coming in with a COPD exacerbation and has no history of smoking. And that's how I landed on biomass smoke and how it's related to COPD. So what is biomass fuel? So the definition of it is very wide. It covers any type of agricultural residue, branches, dried grass, animal dung, charcoal, or how sometimes they make the charcoal with the animal dung and the dry residue, dry twigs and grass. And a lot of people use it because it's the cheapest and most accessible source of energy that people use for cooking and for staying warm. And it's very popular. 93% of households between Africa and Asia alone uses some form of biomass fuel. And let's say, for instance, again, it's the cheapest and most accessible, especially for women that live in rural areas, right? That is what you would primarily use. And let's say, for instance, some areas, in sometimes in Nigeria, where you do have gas and electricity, but it's not widely used due to costs, and sometimes it's sometimes could be unreliable source supply. And which can definitely be an issue as into why although some people might be living in a more um, uh, an area that is that may have the accessibility but may not use it due to the fact that it may be the supply, it might be a supply issue. um, so this is why it's widely used, and again, it's the cheapest. So who carries the burden, right? Well, majority of it is women because guess what? We spend a lot of time exposed to this smoke because we're cooking. And with the prolonged exposure and the problem is this poorly ventilated kitchen. So most places where you're doing outdoor cooking is often in a small hut aside from the house, and it doesn't have a chimney or windows. It's just one way in, one way out, and because women are spending, I would say you know, 3 to 5 hours, but it might be more exposed to that. Um, that is some of the reasons why women are almost at the same equal rate having COPD with men, and that is because also they start at a very early age, right? In a lot of developing countries, young children start cooking at 6 or 8, especially if they're not going to, young girls, especially if they're not going to school, they're starting extremely early. So they have a very prolonged time in a poorly ventilated area, just cooking, and that now equals so that during their lifetime, women exposure to biomass smoke for about 30 to 40 years is equivalent to 60,000 hours of exposure of polluted indoor air. And this is again why women are and compared to men are having COPD at an equal rate despite not smoking. And whereas the men are getting more of this from smoking. So being exposed to biomass smoke from childhood explains why 40% of the people, for example, in with COPD in Uganda, have COPD. In high income countries, of course, COPD is caused by cigarette smoke, and that usually again tends to manifest itself between 15 to 20 years of exposure. With it compared to biomass inhalation, it takes a little bit longer, 30 to 40 years. So beyond the lungs. So here as the mother is exposed. So guess what? Most of the times the kids are right there with mom as she is cooking. And if she is pregnant or even before she becomes pregnant, that biomass inhalation can also cause a low birth rate. And that's in a study in from Guatemala. And then prenatal outcomes. So that also can have stunted growth, and also they can develop nutritional deficits. Um, Early exposure is linked to chronic anemia and stunted growth. So not only mom, but baby and children again are affected by biomass smoke, especially in places where it's not ventilated very well. And then here we have a respiratory impact. So, children, again, living in households are 2 to 3 times more greater risk for developing acute respiratory infection because of how what the smoke actually does to the lungs. So, they can develop acute respiratory tract infections, and they're more likely than to have this infection than kids that are not exposed to biomass smoke. And children under 5 years old, their mortality attributed to acute lower respiratory infection could be over 2 million deaths a year. Because again, the way how that smoke destroys your lungs, they tend to get a pneumonia. So there's been a couple studies that has showed like they started studying this a long time in Nigeria. There's some of these studies are back in the 80s, 70s, 60s, and 70s. But they first were looking at the report of indoor cooking smoke associated with childhood pneumonia and bronchiolitis. And that it showed that's what it was causing. But it's not until the 80s where they started comparing Nigeria to South America and to China, that they really found that this is really causing a harmful effect on minors. And then there was another study that was done in Kenya that showed that biomass smoke pollution, children that are exposed to it, it directly correlates to the high risk of developing pneumonia. Another study in Ecuador showed also in children deterioration of lung function, exposed to high level of indoor pollution. Another one from Guatemala, where they were comparing these children that are exposed to biomass smoke compared to kids that have clean energy. Those kids were more susceptible to pneumonia. Um, Lots of wheezing, lots of complaints of shortness of breath, and more hospital visits. And also in China, they did another study where they just did FEV1s on these kids that are that were exposed to biomass smoke versus the ones that were not, and they definitely had a decrease in FEV1s and peak flow. So what's the link, right? Here we are. We're going to be further analyzing the link between them. So what's in the smoke? The smoke is, of course, very toxic, depending on what you're burning, right? Carbon monoxide, hydrocarbons, organic compounds, free radicals. I mean, and these particulates are what's causing major damage to the lungs, and this is just for cooking. Now, many times, uh, people just burn regular trash. If you're adding plastic and you're adding um, burning tires, like all of those things are also all exposed. Sometimes, again, those are burning outside, but it doesn't mean it doesn't get trapped in the atmosphere and you still can't get sick from it. So here, what it does to the lungs, primarily, um, you have these tiny cilia that are meant to trap debris and help in your goblet cells, produce mucus so that you can trap these things and cough it out, right? But what the smoke actually does is it destroys the cilia. So you no longer have that protection of trapping, catching, and being able to expel because it destroys the cilia. Um, and then again, with the inhaling of the biogas, that fume itself, it has an immune response because again, you have this toxic stuff that's going straight into your lungs, and it stimulates your white blood cells. And again, that overstimulation eventually starts to weaken over time. Hence why some people definitely catch a pneumonia. You have the constant bronchial inflammation and irritation that's happening to the airways because now, again, you've lost the way to trap and clear it. Now it's definitely making its way further down into the lungs. And again, and this is constant, right? This is over 30 and 40 years. And now you have chronic inflammation within the lungs. So one of the things when you're looking at how biomass smoke damages. So with COPD, you have chronic bronchitis and you have emphysema. So smoking primarily gives you um, emphysema. Um, so you have this huge destruction that happens within the alveoli and down in these oxygen sacs, but you also have, again, with the inflammation, this is where a lot of the inflammation is happening and in the bronchial tubes itself. And now especially with emphysema, you have, it starts to change your alveoli ducts, and your alveoli sacs where gas exchange happens, and that starts to diminish how that is performed. You have a lot of structural damages. With chronic bronchitis, you have more of the bronchioles that are mainly affected. And that inflammation within the lining itself, and the bronchial tubes, that inflammation, infection, that now limits airflow to the lungs. It also have a heavy buildup of mucus. So again, biomass, that smoke has, it's damaging the tubes that's coming down, and then sometimes the alveoli sacs. Okay, so where oxygen and carbon dioxide is exchanged. So you have a lot of damage that's happening from the top all the way down to the bottom. And so now here we can compare um, tobacco-related COPD versus your biomass. So they have different phenotypes, right? Again, tobacco smoke is more emphysematous, where it damages, it has a lot of alveoli destruction. Um, um, and biomass is more the small airway. So the bronchioles, terminal bronchioles, is where it tends to do most of its damage. Okay. And with biomass related COPD, you get more wall thickening and fibrosis. Whereas with COPD related tobacco use, you get more elastile recoil. It's less elastile, so that it can't close back the way that it used to. And when you compare which one declines faster, it's smoke, inhalating tobacco is what causes rapid decline, whereas biomass, smoke-related COPD is a slower decline. And again, biomass is again between 30 to 40 years before it really starts to manifest itself, whereas tobacco smoke might be 15 to 20 years before they start experiencing some decline. And again, with the structure, you have you have enlarged airspace and alveoli damage, again with smoking, while you have less destruction of the alveoli. Not saying that you can't, but it's less with biomass related COPD. So here again, more clinical features at a glance. Also, one other thing to stress with biomass related COPD, they tend to wheeze. It's very common for them to be more wheezy, while patients with emphysema tend not to wheeze. They just sound very, very diminished. Um, and here we look at with the airflow, and you have the lung structure. A big thing is definitely the inflammation. The lymphocytes predominantly in the airway inflammation. And again, that chronic inflammation really narrows the airway and causes it to become fibrotic. Um, so that's why there'll be a sound a little bit more wheezy with biomass induced COPD. And you have, which is very interesting, that you can have a mixture of both, where you can both of them will have ear trapping, but it tends to be more severe with the smoke inhalation than compared to the biomass induced COPD. So could you imagine having a patient that smokes and is chronically exposed to this? So they can have a mix, a very much of a mix picture. So also with spirometry testing where available, again, it's it's hard to quite diagnose if we don't get the word out that this can cause COPD, that biomass related smoke inhalation can cause COPD. So therefore, a lot of these people are going undiagnosed because we're not, if anyone is ignorant as I was, where I just thought that the patient just didn't tell me that they were smoking, I just would never would say that you would need to see a pulmonologist. So most likely these patients would have to have had many hospital visits and admission before finally they would probably go and get go get spirometry testing. So spirometry testing is the gold standard, but again, it could be underutilized, and it often may not be available. But what you do find is that their FVC is low, and you have your FEV1 and your FVC are very low once they actually do a spirometry testing. So again, also women who are exposed to biomass smoke have higher alveoli, neutrophils, eosinophils, monocytes, mastocytes, lymphocytes, and macrophages. And so definitely this is why this affects their numbers. So this is what can be done. This is where you guys all come in to help, right? So what we want people to know is that um, it's kind of hard to force down people's throats if they can't afford. If they're using this type of fuel source, it's hard to tell them, hey, you got to change what you're doing. They can still burn it, but all we're asking is that if it's cooking outdoors, is that the most important thing is that if they just add a chimney to it, the better ventilation is what definitely helps. Okay, so to reduce their exposure, it's still low cost. They can still use their source of energy. They just have to try their best to add ventilation, or if it could just be regular outside. Another thing could be cooking in shorter rotations, keeping children away, especially infants, as much as possible. They can also, if not a chimney, it might be extra windows, just so that it helps ventilate a little bit easier. Also, cleaner burning fuels can also definitely help. Again, where available, and if it's affordable. Um, and of course, education, right? That's what we're doing here. And that's what you guys can take back to your patients, to your practice, is to help educate and bring awareness to it. Because I know no one is willfully inhaling this, thinking, yes, I'm just gonna, cause me having to have difficulty breathing later on in life versus people who smoke. Now, they kind of know that they're gonna have issues later on in life. But this one, it's just poor education, and just awareness. You're just not aware that that's causing all of this harm. And with the education, it can I mean, just bringing awareness to it can definitely improve lots of life. I'm just and educating physicians and healthcare administrate people in the healthcare administration, to improve diagnosis of it early on, and to even teach patients what are their triggers and how they can best prevent it. Definitely would help save thousands, if not millions, of lives, especially with children. And so here are some of the key takeaways, right? It's still also with that inhalation, it can also cause stroke, lung cancer, um, again, lower respiratory tract infections, and but it's preventable. 2.9 million premature deaths attributed to household pollution, and we could reduce that. Um, just by bringing the awareness and you guys taking back that information and sharing it, um, can help save lives, help save little babies, and kiddos from having to have a pneumonia, just doing stuff that they don't really, that they really can't help. Um, and moms doing their regular daily work, um, just again bringing awareness to them can save their lives, their babies' lives, and could also help us treat patients appropriately, understanding their backgrounds. Um, so I think it's so important that you guys take this information um, and help change some lives. So I know respiratory care is, depending on where we are in the world, is in its infancy, um, and how important our role is as therapists. So with us being specially trained, it's easy for us to recognize and work with the physicians interdisciplinary to help treat patients. We can help with the diagnosis, again, advocating for patients. We can definitely do a lot of helping with that. And then we can also, help educate. A lot of us do a lot of education as we're treating patients, helping them as they breathe, as we're giving their neck treatments, as we're doing incentive spirometry, as we're doing pulmonary diagnosis. We do help educate patients with this. When you come in and you're extremely short of breath, you appreciate your therapist being at the bedside, the one that's giving you your nebulizer and helping to educate you about your triggers and how best to take your medication, when to come and see your physician. So therapist is very vital at the bedside. And lastly, working with my organization, Global Asthma and COPD Outreach, we help empower lives through education and advocacy. And being on, and since we've done this talk within our organization, um, we've been some of our liaison have been able to go out and educate in churches, in schools, about their asthma and about COPD and how to get treated, and put out this information about biomass. So that is definitely helping to make an impact, and definitely being on this platform, on the ARCA platform, where I'm able to reach more people to help spread this information, to help, save lives by talking to you guys. So I am very thankful for you guys spending some time with us today. I hope you guys learned something not new, but maybe a little bit different, or you didn't think that it made such an impact. So thank you guys.
Any advice to policymakers?
Yes. So, the once you bring awareness to this, policymakers can definitely help advocate. I mean, in terms of um, talking with government officials that can actually make movements to help bring cleaner source of education, source of energy, but also cleaner source of education, right? Depending on where you live in this world, we have different ways that we use our energy, right? And if people cannot afford it, it might just be education or in terms of building different things. Like one of the things that I had seen on when I went to my in-laws that live in Kenya is that they had a wood burning stove that has a built-in chimney. So those things are available. Um, again, helping with infrastructure to do to different towns. I think that they can definitely help with. They would better know the geography and the patient population and the demographics in those areas. So just bringing awareness to them, they can help to formulate a better way to help, again, reduce the burden, because it's also going to be a burden on the healthcare system as well when patients come in. So and in most countries, you do have public and private hospitals, so definitely will help reduce the burden on the public hospital if they bring better awareness, if they spread better awareness and help with good funding to some of these underserved communities.
Okay, thank you. Okay. I think this goes to the Director for Policy and Advocacy in ARCA. I said, is there any way to connect this information, which means information that Malisha Kichwen has given us, to the study of lung life? If so, how can we implement a policy change with these studies? Dr.
Well,
Ngozi, would you like to also share? Well, Malisha, you can go and then Dr. Ngozi maybe.
mhm. Um, Again, this is um, I only learned this year. Um, and as I was working on the research for it, a couple times I would have some articles. So where I work in the ICU, if I'm working on the medical ICU, I'm surrounded by pulmonologists. So as I have some of these studies up or these articles up, they're over my shoulder, like, oh yeah, I've kind of heard about this, but haven't dove into it. And these are pulmonologists. Um, that's actually really good, the stuff that you're working on. So for us, it might take all of us doing a little bit of individual research, because again, different countries have different ways of stuff that they're burning, different resources. So again, this information you're going to take and have to kind of make it into your own, to help drive changes in your local area. Again, I mean, this is now going to be up on the web. But if you want to see some of the links to some of the studies that I've read, you can, always send me a message.
Okay, so on this note, Malisha Kichwen, any last statements that you would want to share with us before
I,
we
I'm very, very thankful to be on ARCA, and to be on this platform to share this information with you guys. And if you guys want to be an advocate or to help within your community, you can always join Global Asthma and COPD Outreach. It definitely is another community, just as the African Association of Respiratory Care, where we are practitioners, home health aides that are just learning how to advocate within our community. And we do some education within there, so we can help spread the word. Thank you guys. Thank you so much for your time.
Thank you. And I would like to use this great opportunity to thank the Africa Respiratory Care Association, our sponsors, Zopec Medical, and our partners and collaborators. We have the International Council for Respiratory Care, Global Asthma COPD Outreach, the Allied Health Professions Council. We have the Relief for Kids, Incorporated, Global Health Alliance, the Breathe Well Initiative. We have Tech, and then we also have the Pediatric Nursing Association of Ghana. Thank you all so much for making time to participate and then for supporting this webinar series. We appreciate you greatly.